Presentation, I'm going to go over eyes and ears, musculoskeletal, neurocognitive, and respiratory. That's on your third exam. Okay, now you should have watched these videos before about the eye. Remember your data collection. I would definitely recommend going over your escape rooms that you did in the classroom. You should have reviewed it at least 24 hours after the class when it's fresh in your memory, because you're going to have to know all those key topics that were on your escape rooms. Okay, that's how you learn how to apply information. You are at a point now in nursing school where your exams are 50% application. So the Kahoots, the booklets that everybody's asking me to do are not going to help you. You need to be doing NCLEX style questions, and you need to be studying daily, okay? So let's talk about data collection. The Snellen chart, you put a patient 20 feet from the Snellen chart. And this is a test of visual acuity. In other words, how well do they see? Cover one eye and then the next. You start on line 3. All right, this is testing cranial nerve 2, which is your optic nerve. Then the extraocular muscle test. This is you're doing the 6 cardinal gazes. Okay, so that's the way the eyes move. So you need to know cranial nerve 3, 4, and 6. Make my eyes do tricks, okay? That's the extraocular muscle test. And that can tell you if there's something wrong in the brain, if the eyes are not moving in every field of gaze. And if you're going to clinical this week, ask your instructor how to do this test, and then you'll understand it a little bit better. Nystagmus. Okay, nystagmus can occur. This is involuntary movement of the eyes. And this could indicate if they do have this, okay? It's only normal on extreme lateral gaze. It could indicate that your patient has multiple sclerosis, an inner ear disease like Meniere's disease, which you need to know for this exam, or it could be they're on medications like phenytonin, okay? When you're giving eye medications, okay, read that over. You need to know how to give eye medications. Abnormal eyelids. This entropion, this means the eyelid could turn in, and then exotropion means that, see, this conjunctival sac is kind of open. That can happen in older adults. Ptosis can happen. Ptosis is when the eyelid is lazy, like it's down, okay? So what happens with ptosis, if it, as you age, you do get eyelid ptosis. And you would look, if it's on both sides, then that's just probably a sign of aging. If it's only on one side, you need to find out if it's new, because that needs to be reported, because that's an indication of cranial nerve 3 damage, okay? Types of eye disorders. We will be talking about eye disorders. Everybody needs to wear sunglasses outside. Everybody needs to protect themselves from the sunlight. Wear a hat. So macular degeneration, read through the risk factors. You're going to have to know that. What are you going to teach them? And then this is how I remember what happens to their vision. AMD, age-related macular degeneration, results in a loss of middle vision, okay? So a blind spot in the middle of their vision. So a blind spot in their central vision. And that is called a scotoma. Anytime somebody has a blind spot, it's called a scotoma. And you may also see scotomas in multiple sclerosis, okay? But we're talking about AMD, so you're going to have a blind spot in the middle vision. Okay, now the other trick to remembering how to treat it is they use an Amsler grid, and the client is taught how to use this daily. They look at this, and it's gridded so that if their disease is progressing, they're going to see less and less of these little boxes, and they may look like wavy to them. Okay, so that's a loss of central vision. Cataracts, definitely got to know it. So know what causes it. Note the opacity of the eye. Also, the risk factors, definitely have to know that. And with cataracts, how I remember they have a decrease in color perception. And I just remember C and C. Okay, they're going to have blurred vision because if you had opacity of your eye, you wouldn't be able to see, right? Decreased visual acuity, yucky night vision, so they probably have stopped driving, hopefully at night. Diplopia means double vision and decreased color perception, which I talked about. And then the vision loss is over time. So the cataract doesn't just appear one day, right? Over time. And usually it's painless vision loss, and they have photophobia. Post-op eye surgery, no matter what time, what kind, right? You're going to kind of group it all into one category. You have to know this. They need to sleep on their opposite side, so not on the side that's affected. Okay, semi-Fowler's position. This is to decrease intraocular pressure. Okay, they have to change the eye patch daily. No sex until the provider says they can have sex. Okay, so that might be a couple weeks, it might be longer. Their eyes are going to be bloodshot. They'll be itchy. Expect white clear drainage. If it's yellow or green drainage, that means they could have an infection. You need to tell them to report increased eye pain with nausea. They need to change the dressing daily, and they need to wear an eye shield at all times, especially when they're sleeping. Okay? No bending at the knee, waist, because that's going to increase intraocular pressure. No coughing, sneezing, vomiting, straining. So everybody needs a stool softener, and that's going to be a common theme in med-surg in a lot of different conditions. Low sodium diet to help decrease intraocular pressure. Limit caffeine. Cannot wash their hair, cannot go in the shower probably in the beginning. In other words, they can't tilt their head back. Okay? No activities that result in increased intraocular pressure. So everybody needs to wear sunglasses when outside. We talked about that. Report any manifestations of infection. Avoid getting water in the eye. And avoid activities like weightlifting that increase intraocular pressure. Glaucoma. So intraocular pressure is measured by tonometry. Okay, so there's primary open angle and there is primary angle closure glaucoma. And this happens when the intraocular pressure rises suddenly and requires immediate treatment. Okay, and this is the type that presents with pain. So with glaucoma, they have tunnel vision. And how I remember this is the U in glaucoma can also be used for tunnel. That's how I remember. So the signs and symptoms, blurry or decreased vision. They could have an eyebrow headache, but most of the time it's painless unless they get this closed angle type. They're going to see rainbow halos around lights and red eyes. If they see yellow halos, that's typically digoxin toxicity. It has to be rainbow halos or halos around lights. Warning signs. They get new glasses and it doesn't clarify their vision. Everything's hazy. They have trouble getting used to dark rooms. They see rainbow color halos and then narrowing vision at the sides of one or both eyes. Okay, so they need a complete eye exam if any of those are present. The treatment, put them in supine position, administer timolol. Timolol, you know the LOLs, they're beta blockers. You probably had that in pharmacology by now. So if you don't teach the patient to press on their lateral duct when they're giving eye drops, this could be absorbed systemically. So you're looking for a low heart rate, low BP, and tight bronchial, they could get spasms, bronchial spasms because of the beta blocker. So you have to be very careful with that. Acetazolamide is a sulfa drug, remember that, so hopefully they're not allergic to that. But it's used as a diuretic. And then mannitol is also, that's an osmotic diuretic that could be used to decrease intraocular pressure. And then, of course, pilocarpine, okay, to constrict the pupil. All right, so retinal detachment, this is a medical emergency. So typically what's going to happen is the patient will say that they see flashing lights. They see like speckles in their vision. Um, so you need to keep their head, maintain it straight because you don't want it to dislodge further. Okay, so restrict head movement. Retinopathy, that happens typically in people with diabetes or hypertension. Um, so people with diabetes and hypertension need to get their eyes checked yearly. The ear, okay, so types of ear disorders. We have hearing loss and conditions of the middle ear and inner ear. So with hearing loss, the causes could be like too much noise. Like, for example, people that work on construction sites and don't wear protective, um, ear plugs, or people that run a lot that have been running for a long time and have blast music in their ears. Okay. So that could be it. The medications that result in hearing loss that are ototoxic include aspirins, NSAIDs, aminoglycosides such as gentamicin, and platinum containing medications such as some chemotherapy. Older adults are going to be more prone to it. And sensory neural hearing loss, which is damage to cranial nerve 8, and that happens with medications. It happens with having too loud noises in your ears at a lot for a long period of time. All right. So with hearing loss, remember patients need to use flashing lights instead of warning sounds for alarms and doorbells. And then care of the hearing aids. Okay, if they're not using it, they need to turn off the battery and remove the battery, and then they put the battery back in when they need to use it again. Okay, use the lowest setting that allows feedback and make sure they're cleaning it. The Weber test. This is a test to determine if hearing loss is conductive versus sensory neural. And so with conductive hearing loss, in Weber test, the way I remember where you put the tuning fork, okay, you put it on the top of the head, and I just remember the W in Weber is the same as a weather vane. Okay, you put it on the top of the head. And if they have conductive hearing loss, hearing is going to lateralize to the affected ear. And then with sensorineural, it's the non-affected ear. Okay, and then negative means they hear it both the same in both ears. Okay, with the Rhine test, this test is bone conduction versus air conduction. Okay, in normal, you have better hearing with air conduction than bone conduction. If somebody has conductive hearing loss, bone conduction is equal or longer. Okay, Romberg test. Okay, this you would do on people to see if they complain about dizziness. You just test their ability to stand up without swaying. Okay, so you have them stand up, put their arms out to the side. You do one with their eyes open and one with their eyes closed. If they start to sway, that's a positive Romberg test. Okay, so expected findings in ear disorders. Middle ear disorders can present with hearing loss, feelings of fullness. I don't know if you've ever had middle ear infections as a child. That's what it feels like. Meniere's disease. This is highly tested on ATI proctors. So you expect gradual hearing loss over time. So they're going to have tinnitus, vertigo, vomiting, nystagmus that I mentioned earlier, and alterations in balance. So safety is going to be a major issue. So you want to, if they are experiencing vertigo, you want them to restrict their head movement, avoid caffeine and alcohol, low sodium diet, change positions slowly so they don't get more, dizzier, I guess. Rest in a quiet, darkened environment. And then space their fluids out, because if they take in too much fluid, that they're going to have more fluid on their ear. All right. Medications. So be careful because these medications can cause drowsiness. So meclizine, that helps with the vertigo. Antiemetics, diphenhydramine, that's Benadryl. Okay, so antihistamine, scopolamine, and diazepam. So scopolamine and diazepam would be used in worst case scenarios. Um, Giving ear medications, remember with adults, you need to move the pinna up and out. Okay, and how I remember that, when you're an adult, you need to move up and out of your parents' house. Okay, that's how I remember that. Now, you can go through each one of these, sheets, okay, and review that, review all those. There's good information in there. But I want to point something out to you, because at this point, I get a lot of requests to do more Kahoots and more Lookits. Listen, you're at a time where your exams are 50% application questions. You need to be in ATI doing questions. I'm not making any questions because you already have access to it. Now, these are all the modules in Engage Med Surge. Alterations in health, alterations in sensory perception has 30 questions. These are all your eye and ear questions. And then mobility, these are all your musculoskeletal questions. So there's 30 questions. Alterations in gas exchange, 30 questions. Then go to Engage Mental Health, and you have neurocognitive disorders, 30 questions. Then ATI, on top of that, has got these standard quizzes you can do that have 20 questions each. In dynamic quizzing, they have custom quizzes where you can do all the musculoskeletal questions. There's 65 of them. Okay, look, neurosensory has 85, respiratory has 42. The other thing you can do is go to dynamic quizzes and put keywords in the search, like dementia. I pulled up 31 questions with dementia, 22 with delirium. Aspiration got me 61 questions, okay? Because when you're taking care of somebody with dementia, you need to know how to prevent aspiration. Um, then you can do other searches like glaucoma. I got 20 for glaucoma. So put in the other conditions into your search and see what kind of questions come out, because that's the same kind of question you're going to have on your exams. Now, you have students in your class that got A's on their exams, and they have probably already mastered this. They know that doing questions is the best form of learning. So please, do the NCLEX questions. Do the work necessary to become a nurse. Also, when you're doing these questions, write down the content you missed. Have a notebook where you're writing all this stuff down. Organize it in a way that works for you, because you're going to need it for the last semester of nursing school, because you're going to be taking a proctor every single week. Okay? So you're going to need to know that information. All right. So let's go to musculoskeletal and see what's here. Now with musculoskeletal, you have your first aid treatments for like strains and sprains, okay? Now remember rice. You always tell somebody to rest. Put ice on the injury for 24 to 72 hours. Every 2 hours for 10 to 20 minutes. Now, we never do ice continuously. We never put ice directly on the skin. So you're going to put like a towel or something underneath the ice, so it doesn't, because you can get an ice burn, so it doesn't burn the skin. We never use heat in trauma or after surgery. Okay, so heat is a no-no. It's always got to be ice therapy to decrease inflammation and edema, okay? And if you're going to use compression stockings, make sure it doesn't cut off circulation, and we want to elevate, okay? Should be done immediately. So rice is the best method after trauma, and then you can do heat after 72 hours, but honestly, most of your questions and NCLEX questions are going to be about ice. Ice after surgery, ice after trauma, okay? Patient frequently. Do not use ice continuously every 2 hours for 10 to 20 minutes. If somebody has a compound fracture, if you come across somebody with a compound fracture, next semester you're going to be learning about military triage. Compound fracture means an open fracture. In other words, the skin is broken, the bone is maybe protruding out. right? So that's an infection risk right away. But still, you never want to put the leg back in place. In other words, you splint as it lies. Okay, so compound means open. The 5 P's of neurovascular assessment, you need to know these because you need to do them Q1 hour after a cast, after surgery. Somebody has orthopedic surgery like a hip replacement. Q1 hours times 24 hours, okay? So, pain, right? And if the pain is out of proportion to what their injury is, think compartment syndrome. You're going to be looking for pain, parlor, poikilothermia, paralysis, paresthesias. So remember your 6 P's, okay? You're going to need to know that. Cap refill should be less than 3 seconds. All right. Poikilothermia refers to the temperature. Usually it's cold to touch. So you want to know that. Make sure you know the 6 P's. All right. So the nursing interventions when somebody has a cast, you're going to ask what kind of material. Is it fiberglass or plaster of Paris? Okay. So fiberglass are all the cute, like colorful casts. Those are fiberglass casts. And the benefit of those are they solidify or dry, I should say, within 30 minutes, whereas plaster of Paris takes a little bit longer, okay? Now, you need to assess for heat as the cast generates. So as the cast is drying, it generates heat, and you want to make sure your patient isn't going to get a burn, okay? Elevate the extremity to minimize swelling for 24 to 48 hours after. Make sure you're holding the cast with the palm of your hands. Don't use your fingers because you're going to make indents in the cast if you do. So burning pain could mean the start of a pressure ulcer. So make sure the cast is supported in if you reposition and there's still no improvement, call the neurosurgeon, call the surgeon, okay? Instruct patients not to use sharp objects to scratch under the cast. This is key. They need to use like a 60 ml plunger syringe and force air, or they can use a hair dryer on the cool setting. Make sure you're watching the temp. If they're permitted to shower, you got to put a plastic bag over the cast. You want to always encourage independence, so a trapeze bar so they can move themselves around in bed. Okay? You want ice bags against the cast, not on top of the cast. When the cast dries, if it's plaster of Paris, it's going to be white and shiny, and it will resound when tapped. Okay, so like tapping a table, you'll hear like a sound. A wet cast is grayish and dull, and it will give a dull thud when tapped. Elevate the limb to prevent compartment syndrome. So that's going to be a theme, whether they have a cast, surgery, or they're pre-op with trauma, okay? Keep in mind that prolonged immobility can lead to disability from frozen joints, okay? How often should the nurse check neurovascular status? Q1 hours times 21 hours after surgery, after trauma, if they're in traction, if they're in, they have a cast, all right? Nursing management of fractures, pain management. If you say you medicate your patient and it's not bringing relief, that could indicate compartment syndrome. You need to call the provider right away because they can lose their limb. It takes, and if the circulation is cut off, you can lose your limb within 6 hours. And you may think that's a long time, but if you've got to mobilize the OR team, that's not a long time. So you got to jump on that right away. So if you've elevated the limb and you gave the medication and within 30 minutes, they're, saying the pain is a 10 out of 10, or it's really high for the level of injury they have, they probably have compartment syndrome. When that happens with compartment syndrome, take the leg or the limb off of elevation at that point, okay? You always elevate the limb if they don't have compartment syndrome to prevent it. But once they have it, you've got to bring that limb back down, okay? in neurovascular assessments, Q1 hour times 24 hours. To prevent constipation, okay, you learn this in fundamentals, so review how to prevent constipation. Range of motion. Why would you do range of motion? Not to strengthen muscles. Range of motion does nothing with the strength of muscles. It helps prevent muscle contractures. Okay. Passive ROM, you should change that joint position frequently too. Okay. Skeletal traction means traction where they actually put pins in the bone, and this makes the patient more prone to osteomyelitis. You need to know osteomyelitis because that's an emergency too. If you see oozing of around the pin site, get a culture. With skin traction, so Bucks traction is probably going to be the most popular type of skin traction you'll do, and it helps to prevent muscle spasms. So usually, typically, if somebody like falls and fractures their hip, they're going to be put in Bucks traction before they go to the OR, because it might take them a couple days to go to the OR. And so Bucks traction can help them feel more comfortable. It reduces muscle spasms. And how I remember that Bucks traction is skin traction is because when you're buck, you have nothing on but your skin. Okay, that's how I remember that. Whoops. All right. So remember all the nursing implications for traction. You did it in a escape room. You've got this mnemonic here. You never let the feet touch the footboard. You make sure the weights are hanging free. And this would be with anybody in skeletal or skin. Weights hanging free, don't touch the footboard, okay? You're checking the 6Ps. You're checking them Q1 hours times 24. Don't adjust the weights. You can pull the patient up without lifting the weights. Don't let the patient touch the footboard. Observe all their, this bony prominences. Make sure you can turn them a little bit. Q2, change the position. Make sure you're looking at the skin under the traction, and the ropes and the slings are not pressing into the skin, and they don't have knots, okay? For pink here, you're going to use whatever solution is the policy at wherever you work, but don't use Provone iodine, so that's Benadine. Don't use that on pins. Make sure you get a trapeze for your patient, okay? Increase fluid intake so that they don't get constipated. The main complication of skeletal traction is osteomyelitis, but it can also happen on anybody with like orthopedic problems. If they had like, orthopedic surgery, they could get osteomyelitis. So they'll get a sudden high temperature, and this is really hard to treat. So you want to try to prevent it with good hand washing. Do everything you're supposed to do, okay? Osteomyelitis is a bacterial infection of the bone. They will most likely, you'll start to treat it in the hospital, but they'll go home with a PICC line, and they're going to have antibiotics for like 8 to 12 weeks. It's very hard to treat, so you definitely don't want your patient getting it. But you have to recognize the signs and symptoms. Sudden onset with severe, intense pain, tenderness at the site, high fever with chills, swelling at the site, headache, and malaise, okay? Compartment syndrome, you have to be able to recognize this. We talked about it. So severe, unrelenting pain, unrelieved by narcotics. Assess for your 6Ps. Hallmark sign of compression syndrome is severe, unrelenting pain, unrelieved by narcotics. The key intervention to prevent compartment syndrome is elevation. Okay, so we got to talk about this. Long bone fractures. Long bone fractures are the type of fracture where you need to be watching out for a fat embolism. So fat leaks out of the bones, gets into the vascular system, and it can lodge in their lungs, okay? So remember, with embolus, it's always like going to be sudden, right? So they're going to have sudden shortness of breath, tachypnea, tachycardia, shortness of breath. The cardinal sign of fat embolized syndrome is a petechial rash on the chest and neck. Okay, they're going to have a temperature and they'll have feelings of impending doom, which means mental status changes. And the reason that happens is whenever you're hypoxic, it sends a message to your brain that something bad is probably happening to you. Okay, so that's how you can remember that. Now with osteoarthritis, you learned about rheumatoid arthritis earlier in the semester. Osteoarthritis is a little bit different because it's non-inflammatory. It's degenerative, so it happens when you get older usually, and it can affect any weight-bearing joint. And it usually only affects 1 to 2 joints on one side of the body, whereas in rheumatoid arthritis, it's symmetrical, right? The risk factors for osteoarthritis include obesity, aging, repeated joint injuries, repeated stress, okay? So remember osteo for the signs and symptoms. So they're going to have outgrowths of bone, so they could have nodes, right? They could have stiff joints, which limit their range of motion, tender joints, pain, and limping. They could have crepitus when they move a joint, and they could also um, the joints are only on one side. Okay, signs and symptoms: pain, stiffness, crepitus, all those things I talked about. Okay, nursing management: you're going to encourage them to do strengthening and aerobic exercise. Um, weight reduction if the patient is overweight, because that puts more strain on the joints. Okay, balance and exercise and rest, and they must maintain weight within normal limits. Okay, post-op care after arthroplasty. So this is total hip replacement and total knee. You got to make sure you're reading your ATI book, your textbook, the chapters on musculoskeletal, because you got to know how to care post-op. It's going to be on your proctors, okay? Hip replacement, you want to make sure you're monitoring for infection. Hip replacement has the highest incidence of DVT after surgery, so make sure you're reviewing the signs and symptoms of DVT. We've gone over it before. Make sure if they're on heparin, you're checking the H&H, the platelet levels, because heparin can decrease platelet levels, right? You wanted to monitor neurovascular status, the 6Ps. So for the first 24 hours, it's going to be Q 1 hour times 24. You're going to administer the anticoagulants. And I don't know if you've had this in pharmacology before, but typically they may start heparin if they get a DVT, but they're going to be on enoxaparin or some kind of anticoagulant after surgery, and you're going to have to teach them how to give themselves a shot after surgery as well, because when they go home, they're still going to need it, okay? Transfer a patient out of bed from unaffected side. Weight bearing is per the surgeon. Use adaptive advices all the time. We always want to use that to make patients independent. And ice to the surgical site following ambulation. Remember, after trauma and surgery, we don't use heat, we use ice. Remember all the nursing implications of ice, okay? Total hip precautions, okay. They can be supine with the head of bed slightly elevated. The effective leg needs to be in the neutral position, okay? Pillow or abductor pillow in place, especially when turning. So if they don't have an abductor pillow, you're going to put a couple pillows in between their legs if you're turning them. And also in bed, they should not adduct their leg, okay? Circulation must be checked after each application of the abductor wedge. Make sure the straps are not too tight because it could decrease their circulation. And you want to make sure you're assessing their skin every 8 hours, but probably more frequently. Okay, total hip replacement teaching. They can lie on the operative side. It's per the physician if they can do that or not. You want to, for 3 months, they cannot cross their legs. Put a pillow, you have to tell them to put a pillow between their legs. It's okay to bend at their hip, but not beyond. So nothing beyond a 90-degree angle. Avoid sitting in low chairs. They have to use elevated seating in toilets. Use straight chairs with arms. Continue the daily exercise program at home. And externally rotate the toes. So avoid flare. Flare stands for flexion. All right, so that's beyond 90 degrees, right? Adduction, which means the legs close together. Internal rotation. Instruct them to use all the assistive devices they need, okay? All right, then osteoporosis. Don't get this confused with osteoarthritis, okay? People at risk, female sex, 50 or older, smokers, people that drink alcohol. Family history of osteoporosis. Anybody that weighs less than 127 pounds. White and Asian people are going to be more prone to osteoporosis because they have small statures, early menopause, sedentary lifestyles. Um, they don't take. Sometimes people don't take in enough calcium. That can be a risk factor, and low vitamin D. So if you get asked what type of exercise helps prevent osteoporosis, remember it's weight bearing, walking, running, weightlifting. Swimming is a great exercise. It's not weight bearing. Okay, so it's not going to help with osteoporosis. What should the nurse do for a traumatic amputation? Wrap it. So say somebody cuts their finger off. Wrap it in sterile gauze. Put it in a plastic bag and then in ice water. Okay. Do not put it directly into water without the plastic. And phantom pain is the thing. So patients do need to be medicated for that. So care of somebody with an amputation. So the big thing with somebody that has had an amputation is that you want to be careful elevating you don't want to elevate the stump because they could get contractures. So you put them prone 3 to 4 times a day to prevent contractures of their stump. So that's important to know. Here's another thing with traction. So make sure you know that. Okay, with chronic illnesses, I know this is a lot, but chronic illnesses is really like fundamentals. You should already know these things, right? So the main goal with anybody with a chronic illness is you want to promote independence. So encourage all those assistive devices, encourage them to be independent as much as they can. We've talked to you already know how to delegate, okay? So if somebody goes into a long-term facility, rehab always starts on admission. Like, what are we going to do at discharge? So you always start on admission to the facility. Okay, so and our goal is always to promote individual independence. Intervention that is helpful preventing contractures, it's range of motion, passive or active. Okay, you would do a TID or QID 3 to 4 times a day. It doesn't increase strength. People that are immobile, you've had this in fundamentals, are going to be prone to DVTs. So make sure they have compression socks on. If that's indicated, make sure they're ambulating, right? And SCDs could also be used, but not together. It's either going to be compression stockings or SCDs. You don't do both at the same time, and they need anticoagulants for prophylaxis. You never massage the legs of an immobile patient because you could dislodge a DVT and cause an embolism. Know your nursing interventions for constipation. You already should know the food's high in fiber. To prevent respiratory complications, remember your expensive spirometer, turn, cough, deep, breathe. And then if somebody gets pneumonia, remember your signs and symptoms, low grade temp, high heart rate, crackles. Now, for literally every condition we talk about until next semester, I'm going to teach you something else next semester, but tachycardia is the first sign of stress in your body. So every condition is going to cause tachycardia, okay? Low grade temp, crackles, make sure you're listening to the lung sounds. Turn Q2 for both the lungs and the skin, okay? Trapeze bar we talked about. um, Prevent falls. So make sure you're reviewing your fall prevention strategies. Um, you never want to put restraints on somebody. You're going to distract them first. Get the family with them if you can. So you don't do it because you have low staffing. Like, remember all those implications of restraints because that's highly tested and you had it in fundamentals. Okay. So make sure you're reviewing those and know when you can apply one. Okay. So you have to get an order, right? Promote independence. What promotes independence? Encourage your patients to pursue a hobby. Okay. Refrain from doing tasks the residents can do for themselves. So it's much better to give them step by step instruction than it is to dress them, right? Give instructions to how to dress. Um, they need mental stimulation, so they need to, crossword puzzles, card games, watching TV shows that are, informative, like travel shows, science shows, etc. Um, the main goal of rehabilitation begins upon admission and it's to achieve optimal function. It's not to get patients back to where they were because they may not be able to, okay? So upon admission. Um, Preventing falls. Make sure you have good lighting. Install handrails. Use non-slip mats in treads. Get rid of, rugs at home too, the scatter rugs. Grab bars are, a must. So make sure the patient knows how to prevent falls. A good way to encourage independence, let the patient do it himself. Give step-by-step directions and encourage the use of adaptive devices. If your patient is having trouble, like say they had a stroke and they can't talk, they could meet a peer that has been through the rehab of having a stroke and having the same type of stroke, to offer some support. Okay, so you want to introduce somebody who's been through a similar situation. You want a chair with sturdy arms for rising, and this one has wheels, so I would be cautious about this, okay, because that could roll back out onto them. Trapeze bar, you always want them to use trapeze bars. Okay, osteoarthritis. Okay, so signs and symptoms I went over. Make sure you review all this, okay? All the information here. And then just compared it to rheumatoid arthritis. You have to know about arthroplasty, and after a knee, they have continuous passive motion. So it goes from flexion to full extension. It's this. You have like a right here. Here's you set it to whatever the physician orders. It's angles of the knee, and this goes back and forth. So it's continuous passive motion. Okay, so it's really important that you know that's after knee arthroplasty. We're going to do neurovascular checks, Q1 times 24 for both total knee replacement and total hip replacement. So that's total, it would be hip arthroplasty is a total hip replacement, and knee arthroplasty is a total knee replacement. So make sure you know the difference. Make sure you know the implications, the patient teaching after, okay? When they have these surgeries, the hip definitely is going to be on DVT prophylaxis after. So you're going to have to teach them how to give themselves a sub-Q injection, okay? That's normal. The knee possibly could, okay? Let's move on to neurocognitive. Okay, so neurocognitive, make sure you know the difference between delirium and dementia. Okay, I know you went over this in class. Super important that you know the dementia difference between those two. You know how to recognize it. Okay, and then make sure you know how to, you're going to notify the provider if you think somebody has it. So usually it's people that get delirium. Usually it's older adults, but it's people that are older adults and have like critical care or, medical conditions. And they're on benzodiazepines or on medications that could cause delirium. So remember that and remember what to do for it. Okay, neurocognitive disorders. So the first one, delirium versus dementia. So make sure you know the signs and symptoms of dementia, the different types, um, Huntington's dementia, um, mini mental state exam. That's like a common thread in ATI for a lot of different conditions. But just remember, if the score's 23 or lower, could mean they have dementia. Defense mechanisms, make sure you understand these. Very important because you need to be able to pick up on them, especially like confabulation. And people sometimes think their loved one is lying, but they're not. They're just trying to fill knowledge gaps because they can't remember. They're trying, and then perseveration, they're trying to maintain their self esteem. So make sure you know what that means. Know the difference between a healthy aging brain and dementia, the signs and symptoms. The 5 A's to Alzheimer's disease, anomia, means they don't know what to call like normal household items. Like they're trying to get their keys and they're like, where's my whatchamacallit? You know, like they just don't know the names of it. Amnesia, they can't remember. Aphasia, they can't say the words they want to say. Agnosia, that means they can't recognize familiar objects. Um, Apraxia, they don't know how to use the objects. So you might give them like a key and they may try to peel an orange with it. I mean, that's just an example. Okay, there are stages of Alzheimer's disease. So the reason I picked Alzheimer's disease is because it's the most common neurocognitive disorder. Okay, and it's neurodegenerate too over time. So read through the symptoms and know that you need to mitigate this wandering because they're an elopement risk. So how are you going to do that? So make sure you're reading the textbook and doing the 5 questions at the end of the textbook. Okay, you should do that in all the chapters in the ATI text and also in Engage. Okay, like I said earlier, you need to do NCLEX questions. That's how you're going to know the most common questions that are asked. Okay, it's a simple formula, and if you do this, you're going to boost your exam grades if you do all the questions. Okay, recognizing cues of dementia, short-term memory loss, check, yes. Cannot remember recent events, yes. May have to confabulate, okay. Needs a list, yes, but I need that too. I mean, most of us need lists, right? Unable to keep track of list, repeats information. So my father is he just turned 89 actually, and he repeats stories again and again because he can't remember if he already told me. But he's getting along very good. He's independent. He's mobile. So I'm very happy for that, and I'm very grateful that I've had it for so long. Um, some of the cues to dementia could be word finding difficulty. It could be they substitute words for something, so they make up neologisms. They make up their own words. That means making up your own words. They could have expressive aphasia, which means they can understand you but can't talk. Receptive aphasia means they don't understand what you're saying, but they may be able to talk, but they're not making any sense, okay? Recognizing cues with dementia. They could be, especially as they progress, okay? They'll be restless. They're no longer empathetic. They're going to have personality changes, insensitive to manners. So in other words, they can be quite rude, and they make poor judgment. They have poor judgment, so they make poor choices. So you would see this as it progresses, okay? Some other signs include trouble parking the car. And when I learned this worried me because I have SUVs and I've always had trouble parking my car. They have to rely on maps for directions. I don't know how valid that is anymore because I feel like we all have to rely on our phones to get us places now, right? Must concentrate or will get lost. True. Sundowning, meaning they get more confused as the sun goes down. All right, so recognizing cues again, they double check their tasks. They need a quiet environment to think. They're easily distracting in a stimulating environment, okay? They need simple directions and thinking process is slower. They may have difficulty with multi-step projects. They stop doing complex projects. So they may stop doing things like travel because the airport is way too stimulating, way too confusing for them. And they rely on others to plan. My father and stepmother will only travel with like my brother and sister. So in other words, somebody else is managing where they're going. They can't do it by themselves anymore. Nursing care, make sure you know how to prevent falls, wandering, um, put them in a room near the nurse's station. Room with a window is always best. Use bed, wheelchair alarms. If they're at home, tell them they have to, the family needs to put a lock up high on the door so they can't get to it. Lock up all medicines, lock up household cleaners. It's like having a child again. You have to protect them. Um, Make sure they have an ID bracelet on if they're home or in a facility, and put the bed on the floor. Okay, so make sure you're reading all those interventions in your textbook. Home care, they need supervision. Oh, make sure the hot water heater is um, cut off at 120 degrees. It shouldn't go more than 120 degrees Fahrenheit. And with oven safety, it might be time for them not to cook anymore. Okay. Tracking device would be good if they could wear that. You want to prevent elopement, which means locking the doors and windows at night. No driving. Need a bed monitor so you know when they're getting out of bed. And alarms and locks on doors and windows. Cognitive support, big clocks and calendars. Pictures are better than words. They need a consistent schedule. They need consistent caregivers. Not too many visitors in the room, right? Remove or cover mirrors because it causes anxiety. They should exercise, so ambulation if they're not ambulating on their own. Make sure they're ambulating. Good lighting and an uncluttered path to the bathroom. Okay, so that doesn't mean their room needs to have bright lights all over the room at night, but they need a well lit path to the bathroom. Make sure the shoes. This drives me crazy when people put shoes beside the bed because that's a fall risk. The mind diet. This can help slow progression. So it's a combination of the DASH and Mediterranean. Flavonols also can help. Those are foods that are high in flavonols. Omega-3 fatty acids, so you should know that from funds, right? Music therapy is very good because it evokes happy memories. It improves appetite and decreases depression. Okay, delirium onset is short. Older adults that are hospitalized are particularly at risk. They could have infection, they could become septic, they could be malnourished, depressed, have electrolyte imbalances, or a history of substance abuse. So those are all the risk factors. Causes include drugs, electrolyte imbalances, liver failure, infection. So remember that retention, urinary or constipation, intracranial problems, uremia, metabolic problems. Okay, so recognize the signs. So they do get quite confused. A rapid personality change. So that's one of the key features distinguishing delirium from dementia is it's rapid. Okay, so they're in the hospital for something else, and they all of a sudden have personality changes, hallucinations, worse in the early morning and night. So again, tachycardia because they are stressed, they'll be restless. So rapid mood swings, paranoid, anxious, okay, inappropriate speech, rambling, okay. Keep them safe. Fall precautions, right? Update their whiteboard, give them fluids, ambulation, vision, and hearing aids. Um, Manage pain and promote sleep. That's what you're going to do for that. And lastly, we have respiratory. Okay, upper respiratory problems. Okay, always hand hygiene, right? Especially during flu season. Um, don't shake hands with people. Encourage smoking cessation immunizations. I just got an alert that they have an RSV immunization available for people my age. Something to look forward to for y'all, but I thought that was pretty neat. I haven't had that message before. Limit alcohol, limit exposure to allergens, cover your mouth and nose with the tissue. If you can't do that, turn the head to the crook of your arm. Try not, it's hard. I grew up with cover your mouth with your hands. So when I sneeze or something, I want to put my hands over my mouth. You're not supposed to do that anymore, right? You're supposed to keep your hands clean. So put your head in the crook of your arm, okay? Rhinitis, this is the common cold. Don't give antibiotics. That's all I'm going to say about the common cold. We've all been there, right? Sinusitis, and that's an infection of your sinuses, and they can get like tooth pain, pressure on their head, and around the sinuses could be tender. Pharyngitis is a sore throat. It could be bacterial or viral. What you're worried about with pharyngitis and also sinusitis is this close proximity to the brain, so they could develop meningitis from it. Okay. So fever, I think you know what to do for a fever. Okay, by now, right? Complications, meningitis. So bacterial infection can cause meningitis. It can cause glomerulonephritis and septicemia. They need to be on droplet precautions if they have meningitis, okay? And they'll do an LP, okay? So with an LP, this is called lumbar puncture. You're going to make sure the informed consent is on the chart. If they have increased intracranial pressure or bleeding on the brain, it cannot be done. Remove jewelry, have the patient void before the procedure because they're going to be on bed rest for a while. Put them in the cannonball position. I think I have a picture. I don't have a picture, sorry. They'll send the cerebral spinal fluid to the lab, okay? So you keep them flat for several hours to prevent a spinal headache and encourage fluids for the same reason. Cancer of the larynx. Smoking is the leading cause, and smoking and alcohol is a recipe for cancer of the larynx, okay? If somebody has GERD for a long time, they can also get it. And exposure to environmental things like asbestos, paint fumes, wood, or coal dust, okay? Treatment is radiation and surgery. So cancer of the larynx, if anybody has a sore throat greater than 2 weeks, or they have hoarseness lasting more than 3 weeks, they need to see a provider, okay? Now, they may do this thing called a laryngectomy, where they take the larynx, they take it out, but then they put a piece right here, almost like a tracheostomy, except this is permanent. They'll never be prone to aspiration after this if it's a total laryngectomy, okay? Because they take the larynx and they put it out to the neck right here. Okay, so it's like a trach, but it's an end stoma, okay? So malnutrition, they can become malnourished after having this surgery. So look for bleeding gums, enlarged liver and spleen, assess their swallowing, because they can eat after, but they're going to be quite sore, okay? With a tracheostomy, remember suction PRN, you always want to give a lot of fluids, make them drink a lot of fluids, and add humidification to the O2 because it thins secretions, okay? You want to suction before deflating a cuff on a trach so they don't aspirate. Make sure you understand the nursing implications of aspiration precautions. The number one thing, get the head of the bed up, right? High filers when you're feeding, or the other thing is mouth care. People with that are prone to pulmonary infections need frequent mouth care, like every 2 hours, with usually a chlorhexidine solution, because you need to get the bacteria out of the mouth because they're going to swallow it. You don't want them to, if they aspirate with those secretions in their mouth, they could get aspiration pneumonia. Okay. All right, so communicating, review the implications of communicating with somebody that cannot talk, because they will not be able to talk with a laryngectomy. So they will need a way to communicate. They can never swim after or submerge in a tub. Um, so that's an important thing to tell them. Okay, conditions requiring intubation with in mechanical ventilation, respiratory arrest, obviously. Anybody that's hypoxemia with a PaO2 less than 60, set up for intubation. Anybody with ARDS, acute respiratory distress syndrome, and then Glasgow Coma Scale less than 8, you need to intubate. No, your oral airways can only be put in unconscious patients. And then endotracheal intubation and tracheostomy. You know that with suctioning, you always have to hyperoxygenate. Okay, so make sure you remember that. All right, let's do lower respiratory disorders next. Okay, influenza. So highly droplet precautions. So make sure you understand the implications of droplet precautions. You had it in fundamentals. Okay, high fluid. You know you want to give fluids. Usually they're treated at home, but older adults may be in the hospital. People die from flu, so it's really important to get your flu shots, etc. Pneumonia, oral care, very important for preventing pneumonia. Aspiration, community, any type of pneumonia, ventilator associated pneumonia, all those to prevent it require good oral hygiene. Okay, risk factors for pneumonia. Anybody with pre-existing conditions like cancer, neutropenia, etc. Drinking alcohol or age greater than 60, respiratory infections, immune deficiency. So I don't have a spleen. I had a splenectomy when I was 5 years old. So every 5 years I get pneumonia vaccines. I started when I was 8 years old. Knock on wood, I haven't got it yet, but I'm very prone to those diseases and I can become very sick if I get them. And smoking, okay? So those are your risk factors. Recognizing cues. So again, tachycardia, one of the first signs because it's stressful. A headache, excessive sweating, so diaphoresis. Pleuritic chest pain. Okay, pleuritic chest pain. That term can happen in a lot of different pulmonary conditions. Okay, so when I hear pleuritic chest pain, that can also occur with an pulmonary embolism. Okay, that means pain when breathing, usually pain when they breathe in. Respiratory rate is going to be increased because they're under stress. They could have organ failure. They could have low O2 sats, fever with chills. They could develop septic shock. So, make sure you identify it earlier, especially with older adults, because older adults may not have a fever with pneumonia. Okay, so you need to advocate if they come in with some of these signs and symptoms for a chest x-ray. Okay, because they might get dismissed because they don't have a fever. But remember, they need a chest x-ray. So they're going to have a high white count. They may have hypoxemia. They'll get electrolyte levels, and then blood culture, sputum, CNS, and chest x-ray. So what you're going to do is suction PRN. You want them to have high fluids so that it thins the secretions, humidified oxygen for copious secretions, at least 8 glasses of water a day. High Fowler's position, encourage turn, cough, deep breathe. And you guys got to pay attention to frequencies every 2 hours, okay? You got to do that suction PRN. We never suction on a schedule. We used to in the old days. We don't anymore, thank goodness. If they're going to have an increased work of breathing. So that means they're going to need high protein foods, right? They're going to have increased metabolism because of that. So increase their calories, fluid intake 2 to 3 liters a day. Okay. Medications, you'll have those in pharmacology, but just make sure you're on time with them. Make sure you know what they do, like the bronchodilators and the methylxanthines can cause like anxiety and tachycardia. Hypoxemia, you need to know the difference between early versus late, because if I come and get report for you and you tell me your patient is cyanotic and you missed all those signs and symptoms before that, that were happening all day long, I'm going to think very poorly of you. Okay? So early, you're going to have the patient's going to be restless. They'll have anxiety and confusion, tachypnea, tachycardia, pale skin, and they're going to be using accessory muscles. Okay, the blood pressure is going to be up. So you need to recognize that earlier. Don't wait until late signs happen when like bradycardia, extreme restlessness, and the skin becomes cyanotic. Cyanotic is a very late sign, and I know students always want to say, oh, they're going to be cyanotic if they're hypoxemic. No, you got to recognize the early signs and symptoms because you got to prevent cyanosis, okay? Tuberculosis, highly tested, highly tested. Airborne, okay, they need to be on airborne precautions. It's a infectious disease. Usually it starts in the lungs, but um, TB can be like in the kid, it can be in a lot of different places, okay? Risk factors, contact with an untreated person, usually people with lower socioeconomic status, immunocompromised people, poorly ventilated and crowded facilities like dorms, prisons, um, lots of people in one apartment, people that are advanced age, people that have traveled to places where TB is prevalent, people that engage in substance abuse, and healthcare workers. Where are the risk factors, okay? Now, the signs and symptoms, classic, okay? This is the classic sign. Patient has a fever in the afternoon, persistent cough, lethargy, so really bad fatigue, night sweats. You hear that? Get them away from everybody else because they need airborne precautions. They need to get away from everybody else. They may have hemoptysis, which is coughing up blood, weight loss, and anorexia. So make sure you understand those signs and symptoms, okay? Because you got to recognize it and get them to airborne precautions. They're going to need a negative pressure room, airborne precautions, an N95. If they go out of the room, they can wear a surgical mask, okay? Take the shortest route. Teach them to cough into tissues. They need a good diet with protein, iron, vitamin B, and C. Encourage fluid intake, especially if they have copious secretions, okay? Treatment is very difficult. It takes 6 to 9 months. They need to come in and get 3 sputum cultures that are all negative before you can say, hey, it's TB is not active anymore, okay? COPD, that's another condition we're going to talk about. There's 2 kind of conditions, chronic bronchitis and emphysema. I'm going to be honest with you, patients usually have both at the same time. So we can kind of put them all in one category, okay? So with COPD, the risk factors are people that smoke or people that work in restaurants. We used to smoke in restaurants, right? And if they work in a bar, for a long time that could happen if they can smoke. There's a rare genetic disorder. Don't worry about that. Usually it's tobacco, 90% of the cases, and people that work in areas where they're exposed to dust or smoke. Okay. All right. So key points: recognizing the signs and symptoms. Okay. They're going to have chronic dyspnea, and sometimes it's very hard to watch some people with COPD because they do have difficulty breathing, and that makes them extremely anxious, and you need to stay by their side. You never want to leave a patient that's anxious, right? They'll have crackles and wheezing. The ABG predominantly will be respiratory acidosis. The respiratory rate, they're going to have tachypnea. They breathe fast, but the respirations are shallow. That's why they have respiratory acidosis. They're going to have a barrel chest. They're going to have club fingers, thin extremities, and big neck muscles from trying to breathe because the work of breathing is increased. Decreased O2 sats and signs of right-sided heart failure, like lower leg edema. All right, so this is a barrel chest. Looks like an apple almost, right? This is a normal chest. And this is clubbing of the fingernails. Okay, for nursing care, you want to make sure they're in high Fowler's or tripod position. Encourage the use of the incentive spirometer. Breathing treatments and medications, make sure they're getting done. Maintain the O2 sat of 88 to 92%, which is good, right? You want to make sure that the oxygen you use, and usually a nasal cannula, is within 2 to 4 liters. You don't want to go over that because that'll decrease their hypoxic drive. 40% Venturi mask is also good. Venturi mask is the most accurate way to give oxygen. Soft, high-calorie foods, make sure you're increasing their fluid intake. And also humidified oxygen is a good strategy to thin secretions. Pursed lips. Instruct to form the mouth like a whistle. Okay, they take a breath in through the nose and out through their pursed lips. Do not puff their cheeks up, and they take it breathing deep and slow. So you have to teach them how to do that. Pursed lip breathing is like the most common type of breathing you have to teach them. Key points: tell them to stop smoking. Probably need a respiratory rehab program. Nutrition. Okay, this is important. So the extra work of breathing increases caloric needs. They need extra protein. So they need a high protein diet. They should remain upright for at least an hour after eating because it'll help them breathe better and maintain normal weight. Incentive spirometer. So make sure you understand how this works, and you're going to tell them to start slow and increase the volume over time. Pulmonary embolism. It happens when a DVT dislodges and is plugged into a pulmonary vessel, okay? It can be minor or life-threatening. 10% of the people that come into hospitals die of pulmonary embolism, so it's preventable. So you really need to know how to prevent this, okay? And we talked about earlier with the musculoskeletal problems that patients can get fat emboli. The difference in signs and symptoms between a pulmonary embolism from a DVT versus a fat emboli is with fat emboli, they have a petechial rash on their chest and axilla around that area and neck, okay? So the risk factors include traveling or trauma that makes patients very prone to DVTs. Anybody in the hospital, anybody with hormones like estrogen, could cause DVTs. There's some genetic conditions, old age, estrogen, malignancies. So there are cancers that you'll be learning about that next semester that are thrombogenic, like pancreatic cancer, just to give you an example. Long bone fractures result in fat emboli. People that have pelvic surgery or people that just had a baby are going to be prone to DVT. People that have had surgery and smoke are going to be prone to DVT, immobilization after 4 to 5 days, and then the people that are sick, okay, and smoke. All right, so the signs and symptoms, okay, remember the mnemonic catfish. So they're going to have chest pain on inspiration, which is called pleuritic chest pain. They could have a pleural fiction rub. They're going to have a cough. They could have an arrest and die, okay? Tachycardia, fever, low grade, they could have that. Diaphoresis, increased anxiety. So there's the feelings of impending doom, which means the patient's hypoxemic. They also can have, it's sudden. So if you have an embolism, the signs and symptoms are sudden. So stay with your patient and call for help if you notice they have sudden shortness of breath. All right, so make sure you know those signs and symptoms. The labs. D-dimer means that's a blood test, and if it's positive, it means there's a clot in your body. Just don't know where, okay? So they may get like pulmonary angiography. That's the gold standard nowadays for that, to see if they have a DVT. Nursing management. Your patient has anxiety and shortness of breath. Stay with your patient. Stay calm. Call for help. Put on the oxygen. Call a rapid if they're like their blood pressure is dropping, etc., and they seem like they're not getting air. Okay, you're gonna call a rapid. All right, chest tubes. You got to know about chest tubes. So the most common type is a 3-chamber chest tube drainage system. But first, let me just say this: it's going to be inserted high, a chest tube, if they need to remove air from the lungs, like when somebody has a pneumothorax. If they have to remove fluids, it's going to be put low. Now that makes sense, right? Because the air rises, fluids are going to drain down. And so this would be appropriate if somebody had like an infection or a hemothorax in their lungs. The chest would be put down low. So for chest tubes, closed chest drainage systems, 3 chambers. So the first chamber is the collection chamber, and this is connected to the patient. And what happens is if they do have drainage, like after surgery, or if they have a hemothorax, it would collect in the collection chamber. The second one is the water seal. And if you see this water seal in the chamber number 2, it's like a straw underwater. So that means air can escape from the chest tube, but it can't go back into the chest tube, okay? And so like if somebody has a pneumothorax, you will see an occasional bubble in the water seal chamber when coughing or on expiration. But you should never, ever, 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 ever see constant bubbling in the water seal chamber, okay? You will see constant bubbling in the suction control chamber, okay? You set that to 20 centimeters of water, but you don't need to worry about that. Just know with the water seal, you are not going to see, you should not see constant bubbling. You should see auscultation of the fluid going up and down when they're breathing. Okay, it's called tidling, oscillating, movement, lots of different words they use for that. But water seal, you should see the fluid moving up and down, okay? All right, so drainage collection chamber. If drainage slows down, look for kinks in the system if you expect drainage. This is the collection. You have to maintain this whole drainage collection chamber below the chest so it can drain air or it can drain fluid. This is the water seal chamber. You never want to see constant air bubbles in that. Okay? You will see, this is a dry pleurovac, but on wet pleurovacs, they'll have another section where suction control chamber that has water in it. Now, don't get caught up between wet and dry. It doesn't matter. It's all the same nursing interventions. So in the water seal chamber, that's where you're going to see the water oscillating. They could have an air leak, but you should only see it if your patient has pneumothorax, okay? And it's an occasional intermittent bubble, not continuous bubbling. If tidling stops in this air leak meter, so in other words, you don't see the water going up and down here, that means the lung has re-expanded, so the pneumothorax is better, or the tube is kinked, so make sure that the chest tube is not kinked, okay? You want to always make sure it's below the level of the chest. So, your chest tube interventions, encourage pulmonary hygiene. Reposition the patient if they complain of burning pain. The chest tube's probably tickling a nerve. Never strip or milk the chest tube because it'll increase interthoracic pressure. You could give your patient a tension pneumothorax. Maintain drainage system lower than the client chest. The chest tube needs to be as straight as possible without kinks, independent tubing, okay? So your interventions, place them in high fallers. Chest tube is done after insertion and when they take it out. Keep 2 hemostats, sterile O2, and occlusive dressing at the bedside. And you document, obviously, the fluid. Okay. Notify the physician if you see tracheal deviation. Remember, your trachea should be midline. Okay, that could mean they have a tension pneumothorax if it's deviating. Sudden onset of dyspnea, O2 sat less than 90, drainage greater than 70 mLs per hour. If the chest tube dislodges from the chest, you're going to cover the area with a dry sterile dressing called a rapid. If it disconnects from the drainage system, you're going to put the end of the chest tube in sterile water below the patient's chest. Okay, that's why you keep sterile water in the room with, a sterile cup. Okay, I think you know transmission-based precautions. Make sure you understand that. And then Lastly, the last thing, here are the answers to the activity in class. So um, one is C, so this is retinal detachment. Two is glaucoma. Three is AMD. And four is cataracts. Okay, this is the vision they're going to see. Make sure you know how it's described. Okay, so this first condition was glaucoma, the second condition was cataracts, third condition was AMD and retinal detachment. If a chemical splashes into the eye, you're going to do continuous irrigation for 30 minutes with normal saline if you have it. If you don't have sterile normal saline, use tap water. If a foreign body is stuck into the eye, the best practice is to leave in place and patch both eyes. Because if you look to the side, both eyes go at the same time. You cannot let your patient eye move, so cover both eyes, okay? Because if they have something impaled in their eye, whenever they look at something, the other eye is going to move in sync, so cover both eyes. Cataracts cause blurring of the vision because the lens becomes cloudy. Cataract surgery is performed when loss of vision affects the quality of life. Glaucoma is often unnoticed until damage of vision has occurred from increased intraocular pressure. And it puts pressure on the optic nerve. Make sure you know what the tonometry reading should be and when it's high. The characteristic sign of narrow angle glaucoma is severe eye pain. So that's also closed angle. Drugs used enhance the outflow of aqueous humor and decrease production. Uncontrolled glaucoma causes blindness. They always have to have their medication with them, and they should have 2 sets in case something happens, and have to take their medicine on time. The sudden occurrence of flashes of colored lights is a sign of retinal detachment. Keep the head still. Retinopathy is often a disorder that occurs in patients with diabetes mellitus. So they have overgrowth, and then the blood vessels with rupture and bleeding. Okay, a patient who's had eye surgery should be positioned with the head of bed elevated and should not lie on the affected side. You got to wait 5 minutes between eye drops. Eye surgery client should not bend over or cough. That is true. Acute angle closure presents with severe pain, but acute open angle is usually okay without pain. That is very true. Okay. Community teaching for prevention of eye problems. Okay, you can look through that. The ear, you can look through these answers. The Romberg test, that's important. The ear drops, know how to give them at room temp. And then when you're talking to somebody with a hearing problem, make sure you're facing them. I think you know all those. We went over that. Here's the answers to the escape room with just the conductive hearing loss versus sensory neural hearing loss. And here's the answers to the respiratory problems. But really, like, you need to be in, here's the answers to the case study. You need to be in doing dynamic quizzing in all those NCLEX questions I was telling you about, because you do need to know these things too. But what I wanted to say is the way you can anticipate what kind of questions you're going to get on an exam are all in dynamic quizzing. So please keep that in mind, and please do the work. I want you all to be successful, so I'm giving you the tips to be successful. Please take me up on it and start doing questions daily in the resources you have, okay? All right, good luck. Best wishes for a successful exam.